And we are live.
All right. Good morning, everyone. It is May 3rd, and this is the Senate Health and Welfare Committee meeting. This morning, we're going to be taking up a couple of different things and try to get to resolution, first on a resolution, and then we'll be looking at H 353, our pharmacy benefit manager bill. So a resolution has been referred to our committee supporting transgender youth and their parents who seek essential medical care for the treatment of gender dysphoria. There's a lot going on in the country right now that's very disturbing, and this resolution is something that we can look at and perhaps make a statement about the state of Vermont's concerns. And to that end, we've invited Dr. Erica Gibson in, who has some history with this issue as a professional. So Dr. Gibson, thank you for being here. And let me just share with you that the committee has not yet been through the resolution, but we will be going through it after your testimony with our legislative counsel. But we know your schedule is your schedule. So thanks for being here.
Thank you. Good morning, Chairperson Lyons and Vice Chair Hardy and members of the Senate Committee on Health and Welfare. I'm really grateful to all of you for the opportunity to be here today to show my support for the joint resolution put forth by Senator Balint and Representative Small to support transgender youth and their parents who seek essential medical care for treatment of gender dysphoria. My name is Erica Gibson, and I'm a pediatrician with a specialty in adolescent medicine. I currently serve as the Division Chief of Adolescent Medicine at the University of Vermont Children's Hospital, where we run the only multidisciplinary transgender youth program in the state of Vermont. Today, I'm speaking not only as a physician who provides direct care to transgender youth and their families, but also as an official representative of the University of Vermont Health Network, the University of Vermont Children's Hospital, the Executive Board of the Vermont chapter of the American Academy of Pediatrics, and the Vermont Medical Society. As expressed in the comprehensive memo released by the Vermont chapter of the American Academy of Pediatrics and signed by leaders of multiple other state medical organizations in April of 2021, we support the recommendation that youth who identify as transgender have access to comprehensive, gender-affirming, and developmentally appropriate health care that is provided in a safe and inclusive clinical space. We know from research and experience in our own program that adolescents who identify as transgender have high rates of depression, anxiety, eating disorders, self-harm, and suicide. Increasing evidence proves that the provision of thoughtful, comprehensive, and collaborative care for transgender youth and families results in improved mental and physical health outcomes. A skilled gender care team knows that every transition is different, and there is no single prescribed approach to care. They work with the young person and their family to provide support, education, and options in order to help them address their individual needs. By passing this resolution, you will be taking an important step towards assuring that transgender youth and families in Vermont feel safe and will have ongoing access to life-saving support and treatment. Thank you for your commitment to protecting transgender youth and their families here in our state. On behalf of our patients and families and the multiple professional organizations that I represent here today, I respectfully ask the Vermont Senate to pass this resolution.
Thank you. And we have your testimony here in writing with a number of signatures representing the organizations that you have listed. So thank you for that. And so I think we'll open it up to questions, and I will ask you one question. I'd like to ask you a lot of questions. But your professional practice obviously works with adolescents in the state who are looking for gender affirming treatment. And so how many do you see in a year? Can you give us an estimate of that? And what's the age range for these kids? And, you know, sort of the gender mix, what are you seeing for the sort of the data on that?
Yeah, so we remain a small clinic, although we are growing, and we have had a total of, I think, just over 200 young people we've cared for since the clinic initially opened in 2015. We will see anyone up until the age of 18. And when they're older than that, they will see young adult care providers in the state. And some families will come in just to have conversations with us. And others will come to us that are ready to engage in actual medical care. We do not actually provide any medical interventions until a youth has reached puberty. So anyone that comes in to see us prior to puberty is just coming in for a conversation usually. And some of those families don't actually come to see us when their child is quite young. They are working with their primary care provider and other supports in the community, and only coming to see us if and when they want and need medical interventions, if that makes sense. So does that answer all your questions?
It does pretty much. And we know that the age of puberty has been dropping down as time goes on. So what are you seeing kids? What's the age that you begin to see them where they're beginning to go through puberty?
Yeah, so for cis females, designated females, puberty is starting as early as 8 years old in some, but for the most part, it's happening a little bit later than that. And for designated males or cis males, puberty tends to start a bit later, so closer to 10 or 11.
Amazing. Yeah. Okay, thank you. Any questions, committee?
I do have a
Senator
question.
Hooker.
Thank you, Dr. Gibson, for being here. Has there been an increase in the number of families that have come to you since the discussion has become more widespread about gender identity?
Yes, I would say that there has been an increase in referrals, and the type of referral has shifted. So when the clinic started, and the clinic was actually started by 2 other physicians, I took it over in about 2018, we had a lot of young people coming to see us who had been waiting for a clinic to open in Vermont, for a very long time. Folks had to travel to Boston Children's Hospital prior to the opening of our clinic. And people were a bit more in need of sort of immediate care because their child had recognized gender dysphoria for a longer period of time. Now that this has become a broader cultural conversation, is a more sort of common part of the lexicon in the country now, and people realize that there can be a spectrum of gender identity. People contact our clinic more often earlier on just for conversations, potentially, I would say. So the type of referral has shifted a little bit also. Does that answer your question?
Thank you.
Senator Terenzini has a question.
Thank you, Senator Lyons. Yeah, I do have a question. In regards to this gender affirming treatment, so a Vermont youth who's hit puberty could come to your clinic, and so what are some of these treatments that one of these youth would be seeking? Is it hormonal pills? Is it some type of a procedure? What are we looking at here?
Yeah, so I'll just clarify that gender affirming care means that we acknowledge and accept and are open to discussion with the young person of what their affirmed gender identity is. It doesn't automatically mean we are providing any interventions unless the young person in the family is interested in that. So the first step for gender transition for most young people is just a social transition where they might have a shift in their gender expression, names and pronouns that they use. And then the next step for folks, especially if they're younger and just in the early stages of puberty, might be a puberty blocker. So that's really not a full blocker. It's more of a pause on pubertal development that is fully reversible. So that those are also used for young people and families that might just need a little more time to sort out what next steps might be, if that makes sense. And those that medication is actually either an injection or a temporary implantable device under the skin that's been used for many decades in the care of other medical issues. So it's been quite well studied. And then further down the line, or for older folks, there might be interest and the option for starting what we call a gender affirming hormone, which might be in the form of either injections or pills or even patches. And families in our clinic are monitored very closely with frequent visits and examinations and laboratory evaluations if they are deciding to start on any medical treatment. And of course, there's a lot more detail that goes into the care we provide, but those are the basics of the actual medical options, to answer your question.
Thank you.
You're welcome.
Okay, any other questions? Good, all right. Dr. Gibson, thank you so much for being here, and you're welcome to stay and listen in while our Ledge Council goes through the resolution with us. And then we'll be moving on after that, but you're welcome to stay for that.
Sure, I'll stay and listen. Thank you.
Okay, good, thanks.
Thank you.
And say hi to everybody. Michelle, you want to come up? And we haven't been through the resolution yet formally, so
I think the version on the website is not the most recent version. Is 2.2 the most recent version?
Yes, but it should be, I don't know, it was introduced yesterday,
Yeah.
so it
this
was
has not been
referred, so
it has more names on it. The referral will have more names on it, but I'm not sure the language was different.
the language is not different,
Okay,
so
I
I'm
wasn't
not
sure if the
sure in
language
terms
was
of what kind of got sent over by the Secretary's office.
So we'll go through what's here, and then if there are corrections, we'll have to make sure we get the
Sure.
right version.
So, good morning, for the record, Michelle Child's Office of Legislative Counsel, and this is my first resolution, I believe, so, I'm not used to this, so I'm just gonna take it through like a bill.
Sure.
And talk to you about it. I don't know how much you want me to go through the language, but we'll kind of hit each of the points here, and if you have any questions about, where.
Yeah, let's
resources
just do
are.
that, just that you were sent some language that might include some of the supporting organizations that we
that's
have, so you can share that with
Yep.
us as well.
So we all are working off draft 2.2. And you'll see it's related to supporting transgender youth and their parents who seek essential medical care for treatment of gender dysphoria, which is, and so I worked with the folks at GLAD in terms of the proper terminology, and this is what they recommended. I know that the term gender affirming care is also used frequently, and I'm not the expert, obviously, on these types of things that interpret, but this is kind of a broader use term of, so that I think the focus of the resolution is on ensuring that transgender children are receiving whatever medical care is recommended and discussed with their medical providers and their parents and guardians.
So you know what might be helpful, I think, is to have a definition of dysphoria, gender dysphoria as used here. And I'm looking at Dr. Gibson. Perhaps there's a definition that you could send us that includes gender affirming care and dysphoria. Can you do that?
Sure. Yeah, we can send you some language on those two, basically.
Thank you very much. Okay.
So the first finding in the resolution is simply that, Vermont values transgender members of our community, and that Vermont has been a leader in ensuring that folks are not discriminated against with regard to gender identity. I meant to look up the year that you passed and added gender identity to the list of protected classes in Vermont, but you did that probably, it's been more than a decade or so, and there was substantial support for that. And so that is a protected class along with sexual orientation and race and religion and things like that throughout our state statutes, just as a little bit of background. The second one is, I believe what the chair was mentioning, is that, so this says that the American Academy of Pediatrics, of Child and Adolescent Psychiatry, and AMA, and other leading healthcare authorities support best practice medical care for transgender youth. And after this language had been sent out to everyone, I did see a copy Desofsky had sent to me on Sunday, I believe, that came from a lot of Vermont medical providers in support of this message. And so that might be something, and or somebody can send it to Alex, or I have it in my emails, and get it to y'all if you don't already have it. It's about the list of.
I think
It's already posted. Okay,
good.
so that might be where you might want to. I was just going based on national organizations.
Sure.
And now that we have this, it might be more appropriate for you to list the Vermont organizations that are supportive of this message.
Or we can say both national and Vermont based.
Sure.
Yeah. Perfect.
So the third one is that, patients, their parents, and their healthcare providers should be deciding about medical care and not politicians. The fourth one is that denying best.
Wait, when I saw that, I said, okay, we need to sort that one out, but no, I'm just, go ahead.
So the fourth one is that denying best practice medical care to support transgender youth can be life-threatening, has been shown to contribute to depression, social isolation, self-hatred, risk of self-harm, and suicidal behavior, and more. There are a lot of resources out there, and I can provide some for you if you want, but it's, I was trying to, in the drafting of this, you can get a little bogged down by the sheer amount of evidence-based data that's out there. And so I was trying to provide kind of a little summary, but there is a lot of information out there if you're looking for studies and resources, and I can assist you with that. Then bottom of the page is that more than a third of the 150,000 transgender youth 13 to 17 years of age live in the 15 states that either have restricted or banned access to best practice medical care or are considering legislation to do so. I believe, I can double check, but I think there are 4 states that have actually enacted the laws, and then there's legislation that is moving in other states that, there's little policy differences here and there, but there are 15 states currently that either have it or are considering it. Page 2 is that whereas parents of transgender children, like all parents, just want to do what's best for their child, and that many face prosecution in some jurisdictions for seeking best practice medical care as recommended by their healthcare provider. So I think folks have heard about. So Alabama has a law that provides for a 10-year felony for an individual who either provides gender affirming care. So it could be a medical provider, it could be a parent. So it's extending beyond just the bans to actually, there could be circumstances where someone in Texas, the governor has directed DCF there to look at this as potentially a violation of the child abuse laws. So parents could be either civilly charged or criminally charged in some other jurisdictions for seeking this type of care for their children. And then lastly, the Vermont recognizes the importance of letting transgender youth know that they are seen, valued for who they are, protected from stigmatizing policies that jeopardize their health and well-being, and supported by a community that wants to see them thrive. And then there's 2 resolutions at the end is that the General Assembly is condemning the actions of states to ban best practice medical care for transgender youth and prosecute parents for seeking that care. And that the General Assembly shall explore all available options to ensure that transgender youth and their families are safe in Vermont to make the best medical care decisions for themselves in consultation with their healthcare providers.
Good, thank you. If we can get the language that adds in the memo from there's, I guess it's a rule or guidance from Medicaid and then the DFR memo. We received a couple of different memos, and I think that's what Jessica asking me. I have that. Go ahead, Senator.
Could we get a list of the states that ban or?
Yes.
Yep. In that list, thank you.
And then you have also indicated that you had, and I think Dr. Gibson probably has more than we can handle, but on the evidence-based data and information, if you have just a list of some of that information.
Can I ask a question about the specific language? Can I ask Michelle?
Yes.
In the second whereas,
Mhm.
I don't know which I think is better, but in the leading health authorities, or should it be leading healthcare authorities? I don't know, a health authorities, not,
Medical care, you were thinking?
I was thinking healthcare
Healthcare.
authorities, but
Yeah, that
these
makes
are
sense.
all healthcare.
Yeah,
organizations
I
that are
think that's a good
Sure.
change.
And I'm sorry, Senator Lyons, you said a DFR memo and then what else? I mean, are these all?
Sorry, Jessica asking, there's a DFR bulletin and there's a Medicaid rule, which I will make sure that you have, that both support gender affirming treatment.
Great, yeah, if you can send those to
I'll send those.
Alex and then CC me, that would be great.
That would be good. If we could get those changes in, then we'll be able to vote on the whole thing.
So when you said changes, you mean just with that,
The
the
language.
one word and then the update of the second one with the Vermont
Yes.
organization?
Yes.
Okay.
Yes, I think probably that's it. I mean,
Sure.
we don't need to spell out organizations that are not medical or healthcare organizations differently from Medicaid or DFR. Okay.
But you wanted those other documents more just for support and for your
Yes,
discussion on the floor.
yes,
correct?
yeah. Okay. Any other questions for Michelle? So if we can get the list of states and then a list or some supporting documentation, evidence-based documentation, that would be very helpful.
Can I ask a question?
Yeah.
You had asked Dr. Gibson for the definitions. Did you intend to have them in the resolution? Did you want them in the resolution? I don't know if that works
I
in
don't think that's
resolution.
necessary. I think it's just important for our edification, and when it's presented on the floor, it would be nice to have that definition in case somebody, we could probably thumbnail it, but it'd be better to have it right there. Dr. Gibson, that would be helpful to us. Also, gender affirming care, because it's a broad term. It means a lot, and it means a lot from the time it begins with a family until the child is an adult and moving through society in a new way. So that would be helpful.
Yes, no problem.
Okay. Any other questions for Michelle? Michelle, anything else that we should be looking at here from your perspective?
I don't think so. You know, again, it's a policy resolution, so it's less kind of a little less involved in terms of.
Can I ask you a question? If we were to put something into law, I mean, we have in the past, we passed a law on conversion therapy and said it's not allowed in our state. And I think that very much relates to what we're looking at here. That was a well done process. So, but the other question is, if we were to try to offer protection to transgender families or transgender youth in our state as a safe haven, what if it were for kids, what kind of reach would another state have if a child were to come into the state of Vermont and look for gender affirming therapy? And they're coming from Texas or Alabama.
Right. I think that's really the really tricky issue here. Our team was providing such care, or parents who sought such care in their home state, and on that issue, it's because we have something called the full faith and credit clause in the U.S. Constitution.
Which clause?
The full faith and credit.
Okay, that's right.
And you might recall, this issue coming up when the General Assembly was working on marriage equality. And so I think you were here during that time, and you were here for civil union, certainly. And the issue is that generally with all the states is that there's a certain degree of deference that states are required to give to the statutes and court decisions in other states. Because if you, let's say, for example, in the context of criminal law, if Alabama has let's take it out of the topic we're talking about, but like say as a 10-year felony for possession of an ounce of cannabis, right? Vermont has decriminalized that, and someone was charged with that crime in Alabama, and then they came to Vermont. The full faith and credit clause, and then we also have extradition, like a uniform extradition law that all the states have essentially adopted. That says that you can't escape the jurisdiction of one state by just going to another state. So we have these agreements and a certain web that works together so that as I said, the statutes and the court decisions in other jurisdictions are recognized by other jurisdictions. And so that really came to light a lot in the issue where we had family law that was quite different throughout the country before the U.S. Supreme Court decision granting marriage equality for everyone. And so when there's a patchwork there, it gets complicated in terms of the default is that we're to recognize the jurisdiction of the other state. There are public policy exemptions for that and how far they could go and what you could do. I think this is just going to be a really evolving area of law when we certainly think of things because there is such polarization in the country right now and states are going in very different directions on this issue, on the issue of reproductive rights, obviously. So I think it's unclear what the options may be. Right now, it tends to look as though federally essentially preempted, either through the full faith and credit clause, but also, let's say, because we have an extradition law, so that basically if Alabama issued a warrant for the arrest of someone who perhaps provided gender affirming care in Alabama and then they came to Vermont, it would be tough to see how you could not comply with that warrant or with that request for extradition for things like that. And so I think this is something that folks are really going to be looking at, a lot of these interjurisdictional issues and how they play out. I don't have a great answer, but
it does open up a really broad conversation that maybe we can have in the future. But
yes, I think there was a story this morning. Did you hear the story?
I did.
This morning.
I was listening on the way down.
Yeah,
absolutely. It was just devastating.
But so that family was talking about if we need to obtain care, then we may move to a state, and you might start seeing things like that.
So here's what I'm going to say. Why don't we let you go and maybe fine tune what we have here based on our conversation, and then we'll look at the new iteration. It'll be 2 point something or 3 point something, and then we'll be able to vote on it and get it out ASAP. We can do that. We'll see where you get to.
Okay,
that'd be great.
Sounds good.
And, just check in if you haven't finished
Okay.
before 10 o'clock.
Okay.
But we can also stand aside on the floor and look at it.
Okay.
Okay, great. Okay, thank you.
Be back soon.
Thank you, Dr. Gibson. I think we're set with this one. And you can take that down so we can see her. For some reason, for anyone who's watching right now out in the real Zoom world, our IT is having a little glitch, so you can't see us, but we can see you. So we're going to continue our meeting without the video because our voices can be heard. But thank you so much, and send us along the information, and we'll be able to use that as we present this to our other Senate friends.
Will do. Thank you so much for having me.
Terrific. Take care.
Bye.
Bye. Okay, so committee, we have on our agenda H353, and Jen, you are here with both a marked up version and a non-marked up. Why don't you come up and And based on the testimony that we took and some sort of legal advice and just looking at what we had in the bill, Jen, why don't you just share with us what we've got?
Sure. Good morning, Jennifer Carby, Legislative Council. We're looking at H353, and I have, I think, posted both draft. Maybe we didn't post the marked up one. Maybe we just posted the clean one, but I have a marked up one if you want to see it.
Does the markup includes the DFR OPR language?
Both of them do.
Okay. Well, one you can see and one you can't.
Right.
Which one should we be looking at?
Let's go through it, and then if there are questions, we can put the markup on there.
Great.
Yeah, I don't want to question.
Yes, and I can sort of direct you to things and
Yeah,
clean version
okay.
that you're getting ready to vote, and there are several pages of struck through language that starts to get unwieldy after a while.
Okay.
So H353, this is the PBM bill. We did not make any changes in the
Draft 4.1.
Draft 4.1. Did not make any changes in the intent section. In section 1A, where it directs DFR to monitor the cost impacts on Vermont consumers of PBM regulation. We added, after talking with DFR and their testimony the other day, this is the impacts of PBM regulation pursuant to this section. So this particular section of statute, which is 18 VSA 9421, subchapter 9 of chapter 221 in Title 18, which is where the rest of the PBM regulation provisions live, and also 8 VSA chapter 107, that's the part that's been added, because that's the health insurance regulation, and the prescription drug aspects of that show up in that chapter. So that is the change there. Then we get into section 2, which is that subchapter 9, all of the PBM, or much of the PBM, direct PBM regulation stuff is in there. And I don't believe you've made any changes anytime recently to most of that, except once we get onto page 8. So toward the bottom of page 7, it says that a PBM shall not require a covered person purchasing a covered prescription drug to pay an amount greater than the lesser of their cost sharing amount or maximum allowable cost for the drug, or the amount the covered person would pay for the drug if they were paying the cash price, and DFR had asked to take out the after application of any known discounts. So in the clean version, you won't see that language anymore. See on line 4 just says the amount the covered person would pay for the drug if the covered person were paying the cash price. The next change is on, you can't see it because it's not there, but it would have been on approximately page 18, I believe, and this is, now we're in section 4, which is in 8 VSA section 4089J, This is the retail pharmacies and filling of prescriptions language, where we were adding a bunch of new language in as, in addition to other things, in a subsection, a new subsection D.
Wait,
So if you're on page 18, subsection D.
yeah, okay.
So what is missing there, so you can see it struck through in an earlier draft, but
We're switching seats.
What?
I just need Ruth just for like 2 minutes. I'll bring her right back.
Musical chairs.
Got it.
Okay.
We're on 353, draft number 4.1, page 18, section 4. Let her get it.
I'm about to tell you what you don't see because
What's
it's
not
been
here.
struck, right?
Okay, so. 4.1. Wait, I've got two, draft 4.1, that's 4.1, okay. All right,
So this is a clean copy.
okay,
So on page 18, in earlier drafts, there was language saying that the health insurer PBM has to permit a beneficiary to fill a prescription at the network pharmacy of their choice, and then not impose different cost sharing requirements based on choice of pharmacy or otherwise promote the use of one pharmacy over another. This is what DFR had one of the ones that DFR had asked to take out, and they had put in some different language in what is now the new D1 that has some similar provisions around choice of pharmacy.
so this reflects the recommendations that we had from DFR.
That's right.
Okay, but you all got the email from DHOT
Yeah,
not supporting this bill.
I did not.
no, they didn't, I think they would support it without,
I want to be sure that when I get a thing that says pharma is referencing lawsuits,
We're
that,
not there yet.
Okay.
that area,
That's
yeah,
a future, an upcoming section that is no longer in the
Okay.
bill.
not in the bill.
Okay, so now we have, the new, what is now, a fairly new subsection or subdivision 3 on page 19. So numbers 3 and 4 are new provisions that DFR had recommended. Actually, this is the OPR recommendation. And have the provisions about health insurers not being allowed to require that a pharmacy designated by the insurer dispense a medication directly to a patient, with the expectation that the patient would transport the medication to a healthcare setting for administration by a healthcare professional. And similarly, in number 4, that the insurer cannot require the pharmacy designated by the insurer to dispense medication directly to a healthcare setting for the professional to administer to the patient. I might recommend adding PBM in here as well, since throughout, I think we have really been talking about health insurers and PBMs. And I don't think the OPR language and that, but I think it makes sense to make sure all your bases are covered.
Where is that exactly?
So I would add a health insurer or PBM on, or pharmacy benefit manager on line 19, page 19, line 19,
Yeah, okay,
and page 20, line 20.
okay.
I just asked a question, I'm sorry, since I got pulled out right at the time when I was.
Yeah.
You weren't, you haven't
You didn't
missed-
miss it
you haven't
yet.
missed it yet.
You haven't missed
You
that.
haven't missed it.
Okay,
You haven't missed
okay.
it.
Thank you, Jen,
Yes.
for having my back.
It's not here.
So now, what you don't see in the bill is what were in prior drafts listed as sections 4A and 4B. So 4A was kind of the long form of the brown bag, white bag, that is shorter language that we just looked at that would take the place of from a non-prohibition standpoint. So that language is out. And then section 4B is, I think, the one that you have raised some concerns about, that is the contract pharmacy, 340B contract pharmacy language that is the subject of litigation in a number of courts around the country right now. So that section is also gone from this clean draft. So we go right into, from that section 4 on the filling of prescription drugs at a pharmacy, to section 5, which is the DFR PDM report.
Okay, okay.
And then the only other change that I have made in the bill is the effective date section. DFR had recommended that the act just take effect on January 1st of 2023, not take effect on July 1st, with a certain portion of it taking effect in January. So the whole.
So it's just all,
This act, yeah.
all right. The part I missed, I was down the hall, is, and I think it's the part that Blue Cross was concerned about, and I think VHI was concerned about, is that they have certain pharmacies that dispense the $30,000 a shot specialty drugs. It's 1% of their pharmacy calls and 53% of the money. If we break down that system and allow every pharmacy to dispense those, VHI is saying it's going to cost the teachers an unbudgeted $1.6 million. That will go on your property tax, by the way, because that's where it is now. Have we undone that system? And
I think you're talking about a section that is not in the bill.
So I think you're talking about section 4, which
Yeah.
is still in the bill,
Yes.
whether that choice of pharmacy language, I think I would want DFR to answer that question, because they're
Yeah.
really the ones who would be administering that. So I think.
And I like, we got DFR, but we never got feedback. Sorry. I missed 3 phone calls because I had it turned off. All right, so.
So I think
Show me
it.
my car insurance.
Jen.
Okay. But
So I do believe there are provisions still in the language that do not allow health insurers and PBMs to kind of create specialty pharmacy designations and only allow certain pharmacies to fill prescriptions for what they consider to be specialty drug. Specialty drug is not a defined term either in our statutes or specifically, with any common definition, generally.
very.
That was.
So that was DFR's
DFR
recommendation.
Yeah.
So I would want them to speak to you.
I mean, that was their recommendation. I'm not sure. We never got feedback from the affected parties.
Well, we could get feedback from the FQHCs right now, because we've taken out 4A, 4B to
Yeah.
affect them.
I would like,
We can bring the insurance companies back in. We have already heard testimony from all those folks, but if you want to go back and do it all
we
over.
haven't heard it since we put in the DFR language. And I wanna,
Here's my suggestion, I think, because of where we are right now in the session. I think that perhaps, Jen, you might want to ship out the language to the interested parties, and we can see their comments. How's that?
I think the language is out there. I don't know. So I am
Okay.
presuming that the people who are
So
interested
the people
are
who are
paying
interested
attention.
are watching, and they are welcome to send in their comments to,
If there are specific people you want me to send language to, I'm happy to, but I don't want to be
Yeah.
the determiner of
no,
who is an interested party.
is there, so what,
was it Michael Cage?
Mark
Mark Cage from
Mark
Beehive.
Page
And Sarah Teachow and, is it Leonine? Well, that is representing, I think it's
that's
Jack Storm.
What are you suggesting, that we send the language to the
That-
lobbyists to get them to approve it? I'm not.
No, not to
sure about that.
approve it. We put in DFR language. I'm concerned, when VHI says it's going to cost the teachers an unbudgeted $1.6 million in additional healthcare costs this year.
I want to give them a chance to respond to the DFR language. We haven't gotten, I want to know what we're doing before we do it.
I believe this language has been in the bill since at least last week.
And the message that VHI sent was on the sections 4A and 4B that are no longer in the bill.
Yeah, we took those out.
I'm not sure that we're, I think, now, I don't know whether what good it'll do at this point, but I think, Senator, I would urge you to connect with the folks that you're concerned about. And we don't want to go back through the whole bill again, but at the same time.
If I can find time, otherwise, if I don't know what I'm doing, I will vote no. I will try and find time, but what I'm figuring out, I'm not gonna get time to eat.
What I'm
between now
suggesting
and
to the
8 o'clock
people who
tonight.
are out in the Zoom world to please contact us about any comments
It's
they
all
have.
of us, I would like
Yeah,
everyone.
no, it's
to get
everybody.
it.
It's everybody. So it's the entire committee, so people who are out on Zoom and your interest in the bill is such that you would like to comment on all the pieces that DFR had brought, and OPR brought to us last week, which includes 1A, page 3, page 7, page 17, page 18, page 20, and then the omission of 4A and 4B.
I will send Alex 3.2 to post as well, just so that.
Oh, good
The
idea.
only difference between 3.1 and 3.2, 3.1 was the markup version that you looked at on Friday. 3.2 just has section 4B, that interference with preferential pricing, taken out. And it shows.
So that's the only
it's
difference in what
That's the
we've
only
done.
difference, and then 4.1 is the clean version of that.
Can we look at, so you're posting that?
Yes, let me send it to.
Yeah, send it to
Hey,
Alex.
can we do that like Thursday, because we have a committee of conference unless they cancel. Both Ruth and I tomorrow at 9 o'clock, right? Double check.
Well, then we'll meet at 8:30 tomorrow because we need to get the resolution out and we'll just have.
We can't vote the resolution out today.
No, because we made some changes to it.
Can I,
I may not be here for that. That's not-
can we hold the vote can we hold the vote for Ann tomorrow if she's not here?
I will do my best to be
Yeah.
here. Why not?
And I will not be here at 8:30, so.
No, we're just
Why
getting.
not? That's fine, if you're doing something.
Yeah.
then
And we can do
it doesn't
this
need to
on
be that.
Thursday, not a problem. I'm worried more about the resolution.
Can I, ask
ahead.
about another topic if we have?
Not yet.
Okay.
Hold that. Hold that thought. Is it 265?
Yeah, just,
Okay.
because, yeah.
Just hold it for 1 minute.
Yeah.
I just want to see that we get the 3.2, is it?
3.2 is the markup version. It's got all the markup from 3.1 with that section that was going to briefly become 4A when 4A went away and had been
Okay.
4B, so I don't want to confuse people too much with that, but it shows it struck with highlighted with lines through it.
Okay, so I'll try to reach out to Mark Agee as well. Okay, Route 265.
Yeah, sorry, this one is a lot easier, I think. On our website, under Katie's name is draft 1.1 of a Hardy amendment, and I just wanted to explain it to you. This is the child advocate bill. This is in appropriations, and I think we're done with Jen's, if you probably have better things to do.
No, I don't want her to
Oh,
leave
maybe
that.
not, okay,
Please,
sorry.
That's a different issue. Go
Okay,
ahead.
sorry. So this is in appropriations, and I've been in twice to talk with the appropriations committee about the bill, and there have been concerns expressed by members of the committee, so I had Katie draft this amendment to address their concerns. The first, if you see, the first instance of amendment just adds language to the establishment clause of the office that it adds the language or through funds provided by the department to make clear that it's DCF and then grantees of DCF. The second, and many of the other instances of amendment, just strike out the word investigate in all instances and insert in lieu of it, respond to in some cases, or just strike out investigate altogether. There was concern that the office would have investigative powers, and what would that mean and how would they do that with the resources and staff that they have. And there are other sort of judicial and law enforcement investigators and DCF investigators, and they didn't want this office to sort of interfere or trump those abilities to investigate. So the office would not have investigative duties, but they could respond to complaints or issues. And then the third issue was a concern about the 48-hour notice of instances of restraint or seclusion of any child or youth in the custody of the commissioner or the department. There was concern that there are actually, depending on how it's defined, restraint and seclusion could happen temporarily, frequently enough that a 48-hour notice would be impractical and not something the department could do. So we moved that up to notification, like with the instances of physical injury and significant harm, and the department would still have to notify the office, but it would be on a 48-hour timeline. The only thing that would be 48-hour notice is a fatality. And again, the other ones are about investigation. So these are 5 amendments. I sent this to the members of the appropriation committee who had expressed these concerns, and they all felt that this substantially addressed their concerns, and they are, I believe, ready to move forward with a vote on the bill with this amendment. Senator Kitchell just said, could I bring it to this committee and either get the committee's approval, and they could offer it as an appropriations amendment, or if we would prefer, we could offer it as an amendment with our names on it. So
Okay.
that's
Yeah,
where it is
good.
right now.
Let's do this. Let's think about this one. I want Jen to show us in 3.2 what's in and what's out briefly. But so think about this, and then the question is, do we want to offer as members of the committee, or would we like for the appropriations committee to offer it? And that is the question. I guess, and originally I thought, well, let the appropriations committee offer it, but I'm either way. I'm happy either way.
Yeah, I don't think it substantially changes the intent or whatever of the bill, but it does make it clear that, especially the investigation part, I think made them feel better. I think it will mean that they'll move forward with the bill.
Let's think about that, and by Thursday, we'll come back to it and have a decision.
Well, they're taking it up this afternoon, so they need us to do something today.
Well, okay.
We'll
have to meet in the corner upstairs then to make a decision, unless you, what do
Well,
you?
if we've already seen this and we don't object, why do we need to meet?
Yeah,
I'm
I mean,
fine.
they're gonna meet this afternoon. It's just a question Jane wanted me, or Senator Kitchell wanted me to find out, would we prefer to introduce it as individuals or have them do it?
Is it easier for them to do it since they're doing it this afternoon?
Yeah, they've
Then
got the bill, just
I'll
let them do it.
suggest that they do it as an appropriations amendment, but we're okay with it. Okay, great, excellent. Thank you.
Okay,
Jen,
if you
just
refresh, you should have
3.2.
3.2.
This shows what?
This shows everything that is struck out of 3.1 and or earlier versions and reflected in the clean 4.1.
Okay,
So the main point of showing you this is to show you that section
okay.
4B, the preferential pricing program language is out.
What page?
So, you're welcome to look at all of the changes. The one on page 2 is adding a reference to the health insurance statutes for what the FR is monitoring the PBM regulation impact. On page 8 is taking out the language about after application of any known discounts for calculating the cash price to determine what is the lesser of 3 price options the patient would pay. page. Where does it go? Starting on page 18, that's the struck through language in what was the one that DFR had recommended taking out about the choice of pharmacy. Page 20, there's the language that I will add for PBM to in 3 and 4, saying that the insurer can't require brown bagging or white bagging. And then down at the bottom of page 20 is where it starts with the strike through of all of section 4A, which was the full brown bag, white bag S242 language. That goes on for several pages. And then on page 26, you can see the language about interference with preferential drug pricing programs prohibited. That language is struck. So page 26, that whole section is struck. And then we get into the underlying bill, section 5, section 6, section 7, and then the effective date has changed. See that?
Okay, so this demonstrates what's been taken out, and then a little bit of what's added in on the statutory references and the change of date. And then the 4.1 shows the bill clean. So folks can look at that, and there
And
are,
I will make a new 4.2, just adding that PBM phrase in a few
Okay.
places in the brown bag, white bag, so that it covers all of this.
and we'll get back to this. I will put it on for Thursday morning so that everyone has an opportunity to comment. And tomorrow morning, it would be great if we could just meet briefly. We could even do it at 8:45, 8:45, and go through the resolution if Michelle Childs is available and has that resolution. We meet at 8:45. And then you won't have to, then you can be off here. You may do your thing, so that will help. And then 265, Ruth is gonna communicate with Senator Kitchell. And we're good, and Senator Hooker.
Did you want to?
I've gotta go, cause I have a bill to do upstairs.
Okay. S 195, if you look at it, it's a pretty minimal report coming back to us, and I'm gonna ask to have the bill recommitted to committee.
Which
For the-
one?
195, the certification.
Certification for peer support.
Yeah.
All it is a report.